Okay, hi everyone. Today I want us to look at one eye condition which is known as glaucoma. Glaucoma. So, glaucoma is one of the leading causes of what we call irreversible blindness. Irreversible blindness. Then cataracts. Cataracts is one of the leading causes of reversible blindness. So glaucoma causes irreversible blindness, while cataracts causes irreversible blindness. So today we will not look at this, but I want us to look at this to find out what exactly is glaucoma and how is it related to what we are referring to as irreversible blindness. Then after that, we shall try to see if we look at the drugs. So this is a very wide area, and if time allows, we'll be able to look at the drugs that are used in management of glaucoma. So let's see what this is all about. So we shall look at glaucoma. We shall look at glaucoma itself, the pathophysiology of glaucoma, what it is, what happens, what are its effects, and then if time allows, we'll also look at the treatment. These are some of the objectives that can be covered under the topic glaucoma. Therefore, there is something called aqueous humor. Aqueous humor, we shall know what aqueous humor is, its flow and production. If time allows, we shall also look at the autonomic nervous system. Which role does it play in the production of aqueous humor in terms of its dynamics? We shall also look at the role of prostaglandins, particularly the issue of aqueous humor dynamics. We will define types and causes of glaucoma. So we shall define what glaucoma is, and later on we shall look at what are the drugs that can be used in the management of glaucoma. So before we get into details, there are some few things that we need to know. We need to know that in layman language, glaucoma is actually related to what we call intraocular pressure. That is when it is increased. Intraocular pressure, you can just in layman's language refer to it as high hypertension. Just the way we normally talk about the normal blood pressure. The eye also has got what we refer to as its pressures. So we shall be looking at it, what it entails and how is it produced and how does it come about. So you need to know that the normal eye pressure is actually 10 to about 21 millimeters of mercury. So this is the normal eye pressure, and anything beyond this figure, that is 21 millimeters of mercury, then we get what we are referring to as eye hypertension, this one, which can now give you this condition here, what we are referring to as glaucoma. So this is the normal eye pressure, and what you need to know is that this disease is a very silent disease, very silent. As we progress, we shall see the types of glaucoma. And one of the commonest type of glaucoma is what we refer to as primary open angle glaucoma. So you can abbreviate it as POAC. This is the commonest type of glaucoma, and we shall see what it means and how patients present. So the most important thing is that we advise patients to do regular eye checkup to check their pressures so that they don't develop what we are referring to as the increased intraocular pressure. So what is glaucoma? Glaucoma is basically a group of eye conditions, and these eye conditions, they actually damage the optic nerve. So the key word here is damage to the optic nerve, and it is usually due to high eye pressure, what we just demonstrated. So we shall be finding out how is this eye pressure come about and what makes it to be high so as to give you this condition we are referring to as glaucoma. So in the definition of this term itself, it shows you that the key words in this condition is damage to the optic nerve. That's why it's a group of eye conditions. The commonest one is related to increased high eye pressure, and this increased eye pressure will damage your optic nerve, therefore, or you'll get glaucoma, and that is irreversible blindness. This diagram here is the diagram of an eye, We usually use it occasionally when we want to demonstrate the structures of the eye, anatomical structures, and sometimes their functions, relation, and so on and so forth. So it's a diagram that we shall be seeing in so many presentations. Basically, you can see what we refer to as the optical system of the eye. This thing here is the cornea. Then from the cornea, you see there's a pupil here. Then there's the iris. Then we have the anterior chamber and the posterior chamber here. Then there is this lens. Then there is the vitreous body. In the vitreous body, we usually has the vitreous humor. Up to this point here, what you see in yellow is just the retinal layer of the eye. And then you can see this yellow layer is continuous towards that direction. And that is what we're referring to as the optic nerve here. So what you are seeing in blue is just retinal blood veins. And what you are seeing in red is just what we refer to as the retinal arteries. And what you are seeing in red is the choroid layer of the eye. And then this whitish part is just the sclera. So all the condition, the beginning of the issue of glaucoma starts at this point here in the posterior chamber of the eye, this section here. So we have ciliary body which produces something called aqueous humor. Aqueous humor. In the eye, in the anterior chamber of the eye, there is a watery, transparent fluid that we are referring to as the watery, transparent fluid. So this watery, transparent fluid is what we call the aqueous humor. So it's produced somewhere there in the posterior chamber of the eye. And this aqueous humor has several functions and benefits to the eye. Some of them include nutritional purposes. And it is this fluid that balances the intraocular pressure. So this fluid is very, very significant when it comes to the issue of intraocular pressure, because one of its role is to balance the pressure within the eye. So as we continue to discuss the issue of glaucoma, then we have to look on the aqueous humor in terms of production and drainage. So we are saying our aqueous humor is produced in the ciliary body. And another thing you need to know that there are three mechanisms of production of aqueous humor. The first one is what we call the active transport. That is the first one. Produces majority of our aqueous humor, over 80%. The next one is what we refer to as ultrafiltration. And then the third one is what we refer to as diffusion. So our aqueous humor is produced through these mechanisms. So these are just the mechanisms. The mechanisms of aqueous humor production. So we have three of them. The mechanisms of aqueous humor production. We have active transport, which produces over 80%, actually around 80 to 95%. These other ones produces less than 10% of our aqueous humor. Active transport uses energy in that process, and it actually uses just the sodium and potassium ATPase pump. This pump here is found on the non-pigmented layer of the ciliary body, and this active transport, which is using energy via the sodium potassium ATPase pump on the non-pigmented layer of the ciliary body, uses also a very important enzyme, an enzyme we refer to as carbonic anhydrase, a very, very significant enzyme. The function of this enzyme is to catalyze a reaction in which CO2 plus water to give weak carbonic acid. So this reaction here is catalyzed by this enzyme here. Okay. The weak carbonic acid dissociates to give us what we refer to as bicarbonate ions. And these bicarbonate ions are the ones that move into the posterior chamber using energy through this pump to create what we refer to as an osmotic pressure that will now pull water plus sodium and chloride into the posterior chamber to give us our aqueous humor. So that marks a short explanation on how our aqueous humor is produced. So let's proceed. There are two ways in which our aqueous humor flows out from the eye, and this is trapezular outflow, and then we have the uveoscleral outflow. So this one is the main one, because after aqueous humor has been produced, it will flow out of the eye back into the venous drainage through trapecular outflow, and that caters for 85 to 90%, while another route known as the uveoscleral outflow takes about 10 to 15%. So you'll realize that whenever we have blockage in this route, what we are referring as the trapecular outflow, then there will be accumulation of aqueous humor in the eye, and that will give us increased eye pressure, which will lead to what we are referring to as glaucoma. So this is what we are talking about. This section you see here is the ciliary body, and these projections you see here are what we are referring to as the ciliary processes. From the ciliary processes, that is where our aqueous humor is produced, and it gets into this point here, what we are referring to as the posterior chamber. And then it moves by convectional flow into the anterior chamber. After it has done its function in terms of nutrition, immunity, plus many other functions, it has to get out through this point into the venous circulation. So it will exit this point here. At that point, you will see in the subsequent slide that we have something, a canal there, which we refer to as Schlemm's canal. And within that area, we have the trapecular meshwork, whereby our aqueous humor exits. So if this route is blocked, then it means what we have produced here, our aqueous humor, will not be able to flow out, and therefore it will accumulate. As it accumulates, it will increase pressure within the eye, and that pressure will exert mechanical impact to the optic nerve and create blindness. So this is a demonstration of how aqueous humor flows. So we will produce our aqueous humor at this point here, this point, what we are referring to as the ciliary processes. After production, our aqueous humor will flow in that direction up to this point. Once it reaches this point, it has two options. The first option is to check the trapecular meshwork route, which we said accounts for about 85% of outflow. That is the first route. And then the next route is the route down here, what we are referring to as uveoscleral route, uveoscleral, which accounts for about 10%. So at this point, we have our trapecular meshwork, you can see. And then we have a canal here, what we call the Schlemm's canal. So from there, our aqueous humor will trickle into that space. It will get into the aqueous veins, as you can see. And then it will get into the episclera, the veins. And then it joins, is drained all through up to the venous, what we refer to as the ophthalmic vein, which will drain our aqueous humor back into the circulation. That is the first route, which is the main route. Then the second route, our aqueous humor just gets through that point there, the uveoscleral space, and then it will trickle into those tissues. Then it will trickle back into the circulation. That is the venous circulation, and then the process continues. So the issue of glaucoma starts at this point here, Whenever there is blockage here, then it means that is the main route and it has been blocked. So once you block the main route, what you are producing here, the aqueous humor, will not be able to get out because this is a minor route and it cannot be able to facilitate the exit of the amount produced here. Therefore, there will be accumulation. There will be accumulation. So there will be trickle back and there will be accumulation of aqueous humor in this chamber. So once it accumulates, it will create pressure. It will create pressure within the eye, and that pressure is what we are referring to as increased intraocular pressure. Increased intraocular pressure. This increased intraocular pressure is what we refer to also in layman language as eye pressure, which is high. Sometimes you can refer to it as ocular hypertension, ocular hypertension. This is IOP. IOP is increased intraocular pressure. So that is basically what happens in this process that leads to what we're referring to as increased intraocular pressure. So this demonstrates what we've just explained. This is a normal eye, but once there is accumulation of aqueous humor, pressure will build up. Once pressure builds up in the eye, it compresses the optic nerve around here. So there will be changes in our optic nerve. And you know the function of the optic nerve is actually to transmit the visual information from the eye all the way to the brain for the interpretation. Subsequently, in this series, at some point we will talk about the visual pathway to understand how the visual information just flows from the eye through the optic nerve all the way to the brain for interpretation. So once pressure builds in this eye, mechanically it compresses the optic nerve, and this optic nerve, its function of transporting or transmitting the visual information to the brain is impaired. Once it's impaired, then you lose your sight. Okay, you lose your sight. So you become blind. So this issue is usually very gradual if it is happening in what we are referring to as primary open angle glaucoma. Sometimes we abbreviate it as just POAC, like this. Usually very gradual, and it's normally detected after it has progressed and the patient has started to experience progressive visual loss. That's why we tell patients to do checkup of their eye pressure. Commonly, if you are a person who experiences headaches, frequent, the word is frequent headaches, that in which there is no any other apparent cause, there's no infection, there are no fevers, but you're experiencing frequent headaches, we advise you to check your eye pressures because this is one of the causes of frequent headaches that are not linked to apparent causes like infections. So we had talked about production and flow of aqueous humor, the mechanisms. We said there are three. There is active secretion, which is the major one. We shall see there's also ultrafiltration and there's also diffusion. So here it takes place in the non-pigmented ciliary epithelium. When you do the anatomy, that is the histology. When you do the histology of the ciliary body, you will be able to appreciate this layer here, what we are referring to as the non-pigmented ciliary epithelium. It's one of the layers of the ciliary body. So that is the site where our aqueous humor is produced, and with active secretion, we get about 80 to 90%, which is the major mechanism. So it requires energy, and that is through the use of sodium and potassium epithets pump together with carbonic anhydrase. So there will be active transport of these ions, that is sodium, bicarbonate and chloride. Mostly this one here, starts with this one. This enzyme here, the carbonic anhydrase, will catalyze production of these ions here, what we are referring to as bicarbonate ions. And once these bicarbonate ions get into the posterior chamber, then it will create an osmotic gradient in which now the sodium and chloride together with the other components of water will be pulled into the posterior chamber, and that is how our aqueous humor will be produced. So you can see water just follows through osmotic process, and this process, the active secretion, is the main target of our drugs that we use in the management of glaucoma. So we can block this enzyme, okay, using what we refer to as carbonic anhydrase inhibitors. So when you block this enzyme, then it means our hydrogen bicarbonate ions will not be produced, and therefore the osmotic gradient will not be created. And therefore, there will be no movement of sodium and chloride and water in the posterior chamber, and therefore there will be no formation of aqueous humor. So patients who come with increased intraocular pressure, and in that case the glaucoma issue, normally use carbonic anhydrase inhibitors also to manage that case. You can also use the beta-adrenergic blockers, that is on the sympathetic division of the autonomic nervous system. So the sympathetic division plays a role in production of aqueous humor. Therefore, if you block these receptors using the beta blockers, then it means you'll be stopping the production of aqueous humor. These are other mechanisms of production. Ultrafiltration just 10 to 15%, diffusion just 3 to 5% of aqueous humor production. This is just due to pressure in the vasculature, particularly the arterial vasculature of the ciliary muscles, and with that hydrostatic pressure, We normally get our aqueous humor produced through changes in the plasma aquatic pressure and reduced reduced by vasoconstriction. So there is vasoconstriction, then there is that creation of hydrostatic pressure, this one, and then there will just be ultrafiltration of intravascular contents, that is our aqueous humor, into the posterior chamber. So this is one of the minor mechanisms. These and these are minor because they just produce minimal percentages. Diffusion, this one just through passive diffusion of lipid soluble substances. And then it depends on the diffusion gradient. It has a minimal contribution to the production of aqueous humor. This is just the issue to mention about the autonomic nervous system in the eye. This is some of the tissues that are supplied by the autonomic nervous system: the iris, the ciliary muscles, ciliary epithelium, trapecular meshwork, and molars muscle and lacrimal. So in terms of production of our aqueous humor, there is an issue here, and then this one is also a concern, and then this one is a concern as well. For example, this one here, supplied by the sympathetic division. When you stimulate sympathetic division of the autonomic nervous system, then it opens the trapecular meshwork. Therefore, it will increase outflow of our aqueous humor. Therefore, we will be reducing intraocular pressure. So that is just one of the mechanisms of some drugs that we use when it comes to management of intraocular pressure. Okay, let's see what's next. Continuation of autonomic nervous system on production of aqueous humor. So we had said beta-2 adrenergic receptors, they will increase production of aqueous humor when they are stimulated. That's why one of the ways of management of glaucoma is to give drugs that stop this pathway. We refer to them as beta-2 inhibitors. So you inhibit this, then that will automatically translate into reduction of production of aqueous humor. When you look at the alpha-2 adrenergic receptors, they decrease aqueous humor production through inhibiting adenine cyclase CNP secretion. So that is just some of the effects of the sympathetic divisions on the aqueous humor production. So that is the continuation. Alpha-1 adrenergic receptors, they cause vasoconstrictions. So the alpha-1 adrenergic receptors, these ones are found in blood vessels, microvasculature, particularly the arteries. So that is where you get the alpha-1 adrenergic receptors. And when we talk of these adrenergic receptors, these are just receptors that are found on the sympathetic division. of the autonomic nervous system. So the receptors that work onto this division are what we refer to as adrenergic receptors. So we have alpha 1, we have alpha 2, we have beta 1, we have beta 2, and so forth and so forth. So receptors that function in the sympathetic nervous division are known as the adrenergic receptors. While in the parasympathetic division, we have the muscarinic receptors and also what we refer to as ionic receptors. So this is the parasympathetic nervous system. On production of aqueous humor, it has no significant effect. On outflow, it increases trapecular outflow, convectional pathway. On the ciliary muscle, it pulls the scleral spur. And once you pull the scleral spur, you open the trapecular network. Therefore, you increase the outflow. On usoscleral outflow, it will decrease the usoscleral outflow because of muscle contraction. So, as we proceed, particularly on drugs, you see drugs can work on receptors. They can also work on enzymes. So, when they are working on receptors, they are doing two things. You either enhance or inhibit. So when you are enhancing, this is agonist, and when you are working against what we call the antagonists. So these drugs can be agonists or they can be antagonists. That is when they are working on the receptors. But when they are working on enzymes, most of them are inhibitors. You inhibit the enzyme that catalyzes the process that results into the pathology that you are controlling. How about the prostaglandins? The role of prostaglandin on aqueous hemodynamics. Prostaglandin F2 alpha. Prostaglandin F2 alpha increases what we refer to as the usuoscleral outflow, and it works on an enzyme we call metalloproteinase enzyme. When you catalyze, when you activate this enzyme, it plays a role in the degradation of the extracellular matrix. Extracellular matrix. Extracellular matrix. So it degrades this enzyme here, this one. It degrades extracellular matrix, and once you degrade the extracellular matrix, you create space within the tissue. Then by so doing, you allow our aqueous humor to flow through this route that we are referring to as the uveoscleral root. And basically from doing that, you enhance outflow of this particular aqueous humor. Something you need to know is that our prostaglandins are effective, and therefore they are the first line agents for lowering increased intraocular pressure in glaucoma treatment. So when it comes to non-conventional drainage issues, then our prostaglandins becomes the first line, particularly if we are dealing with the uveoscleral outflow, not conventional. There are two routes that we use, what we refer to as the trapecular meshwork outflow and the uveoscleral outflow. So our prostaglandins work on uveoscleral route. This one here, not the trapecular meshwork. So mark the difference. This is the main one, this is the minor. Our prostaglandins work on this route, not this one. Very important to note. So when you do an eye examination, particularly the fundoscopy, you will realize that these are the changes you are able to appreciate. Before we talk about these diagrams here, I want to explain something about the optic curve, and optic disc, Okay, optic cup and optic disc. The optic disc, this one here, is the part of the optic nerve It's actually the part of the optic nerve at the point where the optic nerve exits the eye. So the optic disc, this one here, is just part of the optic nerve at the point where the optic nerve is exiting the eye as it goes towards the brain. That is the optic disc, this one here. So what is the optic cup? Optic cup is just a depression. Okay? Optic cup is a depression within the optic disc. So the optic cup, this is a depression within the optic disc. So normally, when the optic nerve is exiting the eye, that point is known as the optic disc. Within that optic disc, there is a small depression, and that is what we refer to as the optic cup. Therefore, it brings us to something known as the CDR. 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 CDR is just what you are referring to as the cup to disc ratio. Very important. Very, very important, because it is from this ratio that we shall be able to tell whether our patient on eye examination is having an issue to do with intraocular pressure or not. So the normal ratio, the normal CDR ratio, normal is 0.3 to 0.4. Okay, so the normal ratio is about 0.3 to 0.4. That is the cup disc ratio. Anything beyond this, if you get, let's say, 0.5, then it means there is compression. There is compression. So 0.3 can also just mean 30% of the total diameter, that is of the optic disc. So that is 30 to 40%. 30 to 40% of the diameter, of the entire diameter. So within this range, that is normal. If you get something, let's say 50% of the normal diameter, then we are talking of changes in the optic nerve, particularly to do with intraocular pressure. So this is how the normal cup optic disc should look like. You see there's our optic cup here, and there is our optic disc here. So when you look at this optic cup, its ratio to the optic disc is small. That is 0.3 to 0.4, or just 30% or 40% of the entire diameter. So when you compare this and this, you'll see there's a difference. You'll see that this one is small, but this one is large. Okay, meaning the CDR ratio here, the cup disc ratio here, is normal. But when it comes to cup disc ratio here, is increased. This simply means there is increased pressure that is compressing our optic nerve. And when you look at the fundus of the patient, this is a normal picture, while this is the abnormal picture. So when we do an eye examination and we look at your fundus, particularly the cup, the optic cup and the optic disc, and we find something like this, then it means we are dealing with a case of probably increased intraocular pressure. So normally you can see even the optic cup here is not very bright compared to the optic cup here. So there's a small optic cup here, there is a large optic cup here. Same thing here, same thing here. So this one is a representation of this, while this one is a representation of this. So this is an increased cup disc ratio, while this is a normal cup disc ratio. So those are the findings that we find out when we examine patients who have the issue of increased intraocular pressure. There are types of glaucoma. We have types of glaucoma, and we have around 5 of them. We have primary, open angle glaucoma, which is the commonest, and it's very gradual, meaning the angle is open, but now the issue is in the channels. You know, we have an issue of the angle, and then we have the issue of channels. So when the angle is open, it's not closed, which means our aqueous humor will come, but we have an issue blockage in these channels here within the trapecular meshwork. So you can have an open angle, but with obstructed or blocked. When you have a blocked channel here or obstructed, but with an angle that is open, then we are referring to it as primary open angle glaucoma. Then we have an angle closure glaucoma. This one is usually an emergence case because it develops rapidly, and it means the angle is closed. The angle is closed. When we talk of the angle, what do we mean? When we talk of the angle, we are talking about when you look at the eye. Let me just make a sketch of an eye here. So if we have our pupil here, then we have our actually the iris, not pupil. And then this is our pupil around here, the lens down there. Okay, let this one be the suspensory ligaments. To hold our lens, this is the lens. This is the suspensory ligament. So this is a lens, this is suspensory ligaments. Then we have our iris here. Our iris is there now. So that we have this one as our anterior chamber, and we have this one as our posterior chamber. So this is where, and we have our ciliary body at this point here. So this is where our aqueous humor is produced as it comes towards the anterior chamber. So when we talk of the ankle is this point here. The ankle between the iris, this is our iris. This one here is our iris. Then this one here is our cornea. So our trapecular meshwork is around there. That is where the aqueous humor is supposed to flow out. So when you talk of closed angle, we're just talking about the angle formed between the iris and the cornea. This angle here. Angle between the cornea and the iris root, the root of the iris. So we have the root of iris here, and we have the root of iris. Root, that's iris root. So the iris root is here. The iris root and the cornea, they form what we call the iridocorneal ankle. That is what we are referring to as either closed ankle or open ankle. Then we have also the normal tension glaucoma. This is where the damage to the optic nerve is there, but the pressures of this patient are normal. Remember, we said glaucoma is a group of conditions, meaning you have other conditions that can damage optic nerve and get an increased CDR. But when you check the IOPs, intraocular pressures are normal. Then we have the secondary glaucoma. This one is normally caused by other conditions. Commonest one is the injury, sometimes diabetes and inflammation. The congenital glaucoma is a rare type. It is found in infants, and the issue is about underdeveloped or incorrect drainage channels. So if a baby is born with underdeveloped drainage channels, particularly in the trapecular meshwork, these patients come with what we refer to as congenital glaucoma. What are the risks and causes of glaucoma? We can talk of the poor drainage. We can talk of family history. We can also talk of age and ethnicity. Whenever there's poor drainage, like for the case of drainage, then it means your trapecular meshwork is either blocked, and when it's blocked, it slows down. The word is slows down. It slows down the outflow. Most of these things we had mentioned. So when you have high intraocular pressure, it will cause high fluid pressure inside the eye. That's a risk to glaucoma. When you have poor drainage, it will just cascade down back to high intraocular pressure because our aqueous humor is not flowing normally. When you have a family history in the family, if you have a family history of glaucoma, that is also a risk factor. Sometimes age and ethnicity. When we talk of age, then it affects mostly the elderly. The elderly are the ones who are affected here. And when we talk of ethnicity, mostly Africans and Asians, they are at high risk of getting this condition we refer to as glaucoma. So other issues include underlying health conditions. If you have diabetes, if you have hypertension, and if you have heart problems, those are also risk issues. If you have a physical eye injury, such as trauma, can damage your structures that are essential for drainage, and therefore it can give you this condition that we are referring to as glaucoma. These are just now the medications. Number one, we have the beta blockers. The beta blockers, their mechanism of action is to reduce aqueous humor production. They inhibit the sodium-potassium ATPase pump. It's called sodium-potassium ATPase pump. It is this pump that pumps the hydrogen bicarbonate ions into the posterior chamber to create an osmotic gradient, so that water from the surrounding tissues can be drawn into our posterior chamber to produce aqueous humor. So when you block this pump using the beta blockers, then you have successfully controlled this condition of what we are referring to as glaucoma due to increased intraocular pressure. So side effects of beta blockers, we have bradycardia. Bradycardia, this is reduced heart rate. Then it can also cause what we call the heart block, bronchospasms. This one is an issue in the lungs affecting the respiratory system. Then we have impotence as well as lethargy. Diarrhea is rare. You normally have hallucinations, alopecia, dermatitis, and sometimes it may mask what we refer to as hypoglycemia. So we had done that already. We have done that. We have mentioned primary open angle glaucoma. These are just repetitions. We have talked of closed angle glaucoma. We have also mentioned something on normal tension glaucoma. This is a typo. This is optic. There's an O here. Optic nerve damage occurs despite the normal eye pressure, likely due to poor blood supply or something like that, which increases the nerve sensitivity. We also mentioned about the secondary causes of glaucoma. When we have eye trauma, inflammation, that is uveitis, particularly anterior uveitis mostly, diabetes, long-term steroid use, and eye tumors, they can actually predispose you to glaucoma. Then we also mentioned about congenital causes. This one comes at birth, and the issue is all about poor development, poor abnormal, mark the word abnormal, development of drainage structures. Those are the keywords. So in neonates who are born with abnormally developed drainage systems of the aqueous humor, they will present with what we are calling the congenital glaucoma. So we had mentioned drugs. We have beta blockers. Example is timolol, petoxolol, and levobinolol. Mode of action on aqueous humor production, they reduce it. We have formulations and dosages. For eye drops, we give 0.25 to 0.5%. That is 1 to 2 times a day. The side effects locally in the eye, you'll feel some burning sensations and sometimes dry eye. Systematically, in the systems we had mentioned, particularly on cardiovascular, you get bradycardia. Bradycardia, we said, is just reduced heart rate, reduced heart rate. That is what we are calling the bradycardia. What you need to note is the beta blockers are contraindicated in asthmatic patients. Remember, the beta adrenergic receptors, beta adrenergic receptors, particularly beta 2, they are also found in the lungs. They are found in the lungs. So, if you stimulate these, you stimulate the beta 2 adrenergic receptors, you get bronchospasms. Bronchospasms. This one here. So if you get bronchospasms and you are an asthmatic patient, it will just trigger asthma, or it will worsen the condition. That's why these drugs, the beta blocker inhibitors, are contraindicated in asthma, what we call COPD, chronic obstructive pulmonary diseases, together with the heart block. You can only diagnose this one if you do an ECG. If you do an ECG, you will be able to detect if your patient has a heart block or not. We shall mention about heart blocks when we'll be looking at the ECG in one of the 5 days. So we'll look at ECG at one of the 5 days, and we shall be able to talk about the heart block. But ECG helps us just to check the electrical mechanisms of the heart. Remember, the heart has got 2 mechanisms of action. It has the mechanical activity, which is normally checked by what we call the echo. If you do an echo then you are looking at the mechanical activity of the heart. But when you do an ECG, then you are checking the electrical activity of the heart, how an electrical impulse is generated, how it circulates within the heart, and how it triggers the heart to function. So that is a topic of another day. We mentioned about carbonic anhydrase enzymes. This is an enzyme that plays a very big role in production of aqueous humor because it catalyzes the formation of weak carbonic acid, which then dissociates into hydrogens and hydrogen bicarbonate ions, which again are deposited into the posterior chamber using an ATPase pump to produce an osmotic gradient that now draws water from the surrounding tissues to form our aqueous humor. So this carbonic anhydrase is a very active and important enzyme in terms of production of aqueous humor, and that is why in the management of increased intraocular pressure, we want to inhibit this enzyme to reduce production of aqueous humor. Remember, our aqueous humor is the one that is contributing to increased intraocular pressure, which is now giving us glaucoma. So we want to reduce increased intraocular pressure by reducing production of aqueous humor. So we can reduce production of aqueous humor by blocking this enzyme here, because that enzyme has a significant role in production of aqueous humor. So examples of drugs we use is dorzolamide and brinzolamide, and orally we have acetazolamide. So the mode of action is just to inhibit carbonic anhydrase. This is an enzyme. So by inhibiting that enzyme, we are effectively reducing aqueous humor secretion. So this class of medication has various formulations. We have the eye drops. So the eye drops we give 2 to 3 times daily. Then for oral tablets, we normally give 250 milligrams to 2 to 3 times daily, actually for a short time. Side effects of these drugs is that when you give topically on top as a drop, then you'll have a stinging feeling. Also, you can experience bitter taste. On oral medication, it will give you metabolic acidosis, this one here. It will also give you hypercalcemia. It can predispose you to kidney stones or paresthesia. Sometimes we overlook side effects if the benefits of this drug supersedes the side effects. Remember, every drug has side effects. There is no drug that doesn't have side effects. What we normally do after evaluating the patient, you weigh the options, and if the benefits of this medication supersedes the side effects, then we give this medication. We have alpha-2 adrenergic agonists. One of the examples is brimodine and apraclonidine. Their mode of action is to reduce aqueous humor production and then increase the use of scleral outflow. They come in formulation of drops, and you give 2 to 3 drops. You give eye drops 2 to 3 times per day. When you are using this medication, you can get some few side effects. That is dry mouth, fatigue, allergic conjunctivitis, sometimes CNS depression in children. We had also mentioned about prostaglandin, their role in production and outflow of aqueous humor. So when we give the prostaglandin analogs, which are the first line drugs, then we are increasing outflow. And you are increasing outflow using which route? We said there are two routes. We said you have the trabecular meshwork route, and then we have the uveoscleral route. So we said the prostaglandin don't act here, but they work here. So they will increase aqueous humor outflow through the uveoscleral route. I believe we've been able to see or learn something about this condition called glaucoma. And therefore, I would like us to end at that point until we get to meet into other presentations. But for today, I think this bit is enough. The topic is very, very long and wide, but at least we've gotten a few or two things, particularly on eye health. Eye health. So, we are reminding you to subscribe to our YouTube channel. On our YouTube channel, our YouTube handle is just Dr. Manala. So you search this handle. You start with this symbol at, which is attached to Dr. Manala. You will get our YouTube channel, which is known as the Optic and Eye Health. So you'll get our YouTube channel, which is known as the Optics and Eye Health. You can subscribe, you can make a comment, you can give an input, you can ask a question as we make the sessions interactive. So I want to say thank you for being part and parcel of this presentation. Just to wish you good time as we progress. Thank you.